Hi, I'm Brian Finestein, CEO of St. Clare's Health. Welcome to Let's Talk Health. I'm here with Dr. Huang, one of our general surgeons and president of our medical staff, and we're here to talk about gallbladder disease and hernias. So, Dr. Huang, welcome.
Thank you, Brian. Glad to be here.
So let's start off, gallbladder disease. Tell us, the listeners, really, what is the function of the gallbladder, first of all?
Yeah, absolutely. So the gallbladder is an accessory organ that everyone has. We need that organ to absorb fatty meals. It is, however, though, the liver that makes and produces the bile. What the gallbladder does, in essence, is acts as an accessory organ or reservoir. So any bile that does not get used up by the body gets then restored back into the gallbladder and gets used for the next meal. And so how it works is that when you're eating any type of meal, the brain sends signals to your GI tract that you're having a meal, and the stomach and the gallbladder and liver start to excrete the bile. And the main purpose of the bile is to absorb fatty meals. So that's essentially the main function of it.
So now people talk about, their gallbladder is bothering them. Actually, what are the symptoms that people should be looking for?
Yeah, that's a great question, because some people don't even know they have gallbladder problems. So one of those symptoms are, the most common or classic findings, so to speak, are pain after you eat. Usually occur either immediately, 30 minutes, sometimes a couple hours. And the most common location is in the right upper quadrant, underneath your right rib cage, sometimes epigastric, right here in the middle. And the pain can radiate to the shoulder or scapular region in the back, or sometimes right through. Now, other symptoms, not always consistent, but could be bloating, crampiness, nausea and vomiting. And interestingly, some of these symptoms can occur at various different times of the day too, not always associated with eating. It can be in the middle of the night. I've been doing surgery for 20 plus years. Midnight, 3 a.m. seems to be one of those times that wakes them up. And one of the other things that gets sort of confused of what it is having the pain sort of in the epigastric or retrosternal area. So people think they're having a heart attack, and that sometimes brings them right into the emergency room. Rightfully so, I think, to be cautious. And then when they do an extensive workup of the heart to make sure that it is not a heart attack, the ER physician then usually thinks of the next organ, which is sometimes the gallbladder, and they'll initiate that workup then.
So we think we have a problem with our gallbladder. How do you diagnose it?
Yeah, so sometimes, like I said, you have sometimes a postprandial sort of discomfort or pain. Some people would say, oh, I had that meatball sandwich or pizza and a little twinge of discomfort. Some people will just ignore it, and some they think it's just acid reflux. Others will then sometimes go to their primary care doctor. And upon listening to all those other symptoms, usually the physician may order an abdominal ultrasound. That's the first step sort of for imaging study to examine the gallbladder, besides the usual lab work such as liver function tests.
So that's a non-invasive test.
Non-invasive test. Other studies that physicians order are CT scans, as well as a nuclear medicine study called HIDER-scan. It's a long acronym, but it studies the function of the gallbladder itself. But usually the first step is an ultrasound of the abdomen.
There's also some people talk about having gallstones. What is that?
Yeah, gallstones are not quite the same as kidney stones. So about 80% of gallstones are cholesterol stones, and the remaining 20 are pigmented stones associated from metabolic diseases from the liver. But the most common one, like I said, were cholesterol stones, and they're usually diet related. So it's too much cholesterol in your diet that saturates the bile, that then starts to form the crystals and the propensity of forming stones. Foods rich in cholesterol are fatty meats, shellfish, dairy products, and eggs. Not to say they're all bad, because we do need that. Cholesterol actually is a good substance to ingest, but because we need it for normal cell function. But too much of a good thing is not good in that sense.
So both are potentially related to diet, both gallbladder disease, gallstones. So you have that, Is that the first order of business that you ask the patient to adjust their diet?
Yes, absolutely. That's the easiest sort of modification you can recommend to a patient. But it's the hardest one to make. You know, some patients, you know, will say, okay, I'll eat less of a hamburger or steak, and it's their vice. But yeah, that's the first thing you recommend, to try to do it medically and not surgically. Diet modification.
So you mentioned that. So you have it and you're still having difficulty because you're still having too many burgers or too many steaks. What's the medical regime to hopefully treat the gallbladder disease successfully?
Sure. So the natural progression after, let's say, you've tried the diet modification, is there's another product, substance you can, not substance, medication you can use medically. It's called Actigall. It can sort of dissolve smaller stones or sludge. It's, however, not as effective. Ultimately, like you said, Brian, it'll recur again. The symptoms will come back, and eventually it becomes so persistent or debilitating that patients then will elect for surgery. So the natural progression after, let's say, if 2 or 3 episodes, or if the frequency increases, then the recommendation is to have elective surgery.
Okay, so you go through that. What's the recovery time?
So it depends which approach you use for surgery. So there are different modalities. You can use the traditional open, which really is more reserved for either very difficult, challenging cases, or when you have to do certain duct explorations to extract the stone. But nowadays the standard is what's called MIS, or minimally invasive surgery. So we have a combination of laparoscopic approach and the robotic approach. Depending on the surgeon's training and skill level, most surgeons do it laparoscopically, but now the newer transition, so to speak, is towards robotic surgery. The ports, the number of, so to speak, instruments we use for minimal invasive surgery is similar, laparoscopic versus robotic. It's just dependent on surgeon's training.
Okay, so you have it on Monday. When can you resume normal functions in your life?
Yeah, so, you know, for a straight elective procedure, most patients, like you said, they'll come in on a Friday morning. Surgery on average can take anywhere between 30 minutes to an hour and a half, depending on how difficult the case is, or how easy it is done. But they go home the same day, and the typical recovery for minimally invasive surgery, laparoscopic, robotic, is about 1 to 2 weeks. And, you know, some people recover faster than others. These are more for the elective surgery where the symptoms are more benign, meaning you've had a twinge, you had some discomfort. It's not compared to what we call acute cholecystitis, when you have fulminant infection of the gallbladder. So for more the elective, benign cases, the recovery is pretty quick.
Future, you've had your gallbladder out. How does that affect your diet? Or am I good to have burgers and steaks?
Absolutely. I'm not going to hold that away from you. So you certainly can have pretty much all the foods that you'd usually tolerate. My usual recommendation to patients, though, is still to practice sort of a healthier diet anyway. You will be able to still tolerate the fatty meal, so to speak, if you have Memorial Day weekend with a steak or burger. Sometimes some patients, though, experience some initial, so to speak, GI symptoms of crampiness or diarrhea. Those are sometimes self-limiting, but again, like I said, majority of people have no issues and live very well without the gallbladder.
Okay, so there are other organs that take the place of the functioning of the gallbladder then?
Absolutely. It's the liver that still makes the liver, produces that we need for digestion.
Okay, thank you. So let's shift gears now to talk about hernias. So talk about exactly when someone says, I think you have a hernia, what does that entail? What is that about?
Yeah, so the hernia is what we call a sort of outpouching or defect through either muscle layers or tissue layers. And what the common sort of presentation is that patients come to me for, or to the primary care doctor, is they feel a pain or a bulge in a certain area. So the types of hernias, there are the most common ones are called inguinal or groin hernias. Then there are what we call belly button hernias or umbilical hernias. There are ventral hernias, incisional hernias. These are hernias that occur after surgery sometimes. And then there are what we call hiatal hernias. These are more high up in the chest where the stomach can slide up and cause some problems too.
So again, you think you have one of these symptoms. How does that get diagnosed?
Yeah, like I said, most pick up sort of early symptoms you hear about as the pain or discomfort, and then patients will tell you they notice a bulge while they're showering. So we'll focus on the inguinal hernias. They'll see their physician or get referred to a surgeon like myself. And as you listen to the symptoms, you ask if there are any issues with the hernia. So what can slide through the hernias are other organ parts of the body inside. So intestinal loops as well as fatty tissue can slide through, and they can cause pain or pressure. And then on physical exam, you examine the groin or the inguinal canal, and you can actually feel sort of the outpouching and pushing of the hernia sac itself. And that's usually the first step to examine the patient.
Now, it doesn't sound like there are medical treatments for a hernia repair.
No, well, again, just like with the gallbladder, you can make some recommendations to modify your lifestyle. So a lot of these hernias occur when there's more added, so to speak, pressure on the groin area. So if you're lifting heavy objects, smoking doesn't help because some people have chronic cough. So you can recommend those sort of modifications, but those are sometimes not easily, followed. So when you get to that point where it becomes more frequent and unbearable, the next step then is to recommend surgery.
So can you tell us what that entails? So you decide you're going to have your hernia repaired, and we're putting ourselves in your hands.
Yeah, so just like for the gallbladder, there are different approaches. So the traditional open approach, which is an incision over the groin area of the side that's affected. And then we have, again, the MIS approach, laparoscopic or robotically. On an open repair, the incision is obviously bigger. The recovery time is a bit longer, about 2 to 3 weeks. And then you can resume, so to speak, full strenuous activity in 6 weeks. For the minimally invasive approach, it is a lot shorter, about 1 to 2 weeks of recovery on average, with resuming heavier loads of activity within 4 weeks. In the hospital, you actually experience also a quicker recovery with the minimal invasive approach.
As a patient, who decides? So I go in and I'm thinking, I want the one that is least disruptive to my life. So, Dr. Huang, I'd like it robotically or minimally invasively. How do we decide?
Good question. The outcome really for both open and minimally invasive should be the same if they're repaired correctly in the right way. It does entail placing mesh that's permanent. Although the approaches are different, like I said, the outcome should be similar. So to your question of what approach do we use and who decides, it's, I usually, the way I do it is I tailor it to the patient. Depending if they've had previous surgery there before, I'll have to decide whether an open or robotic approach is a better one to fix that. But ideally, nowadays, again, the trend is moving towards MIS and having it done that way. The incisions are very small. They're just about the size of your finger breadths. You have 3 small incisions. Like I said, the recovery is much shorter, and the pain also is a lot less than when you have it done open. So preferably, most people choose the MIS route before they do the open.
Thank you, Dr. Huang. For this segment and future segments of Let's Talk Health, please go on our Facebook page. And for past segments, please feel free to reach out and see it on our YouTube channel. Thank you.